Usually, when you talk about a medical diagnosis, there's this expectation of like mechanical precision,
Right.
right?
Like a visible proof of the problem.
Yeah, exactly. You break a femur, the radiologist points to that jagged white line on the film, and the orthopedist sets the bone. It's binary,
It's totally visible.
right? But you step into the world of trauma neurobiology, and that X-ray machine just completely shatters.
It really does.
We are operating in a diagnostic landscape that requires an entirely different level of clinical deduction. And nowhere is that more apparent than when you're staring down the psychiatric aftermath of trauma.
Absolutely.
So welcome to the deep dive. If you are an advanced PMHMP or a psychiatric clinician, you're in the right place. Today's mission is highly specific.
Very specific.
We're extracting the core clinical pearls from some serious heavy hitters, the DSM-5, Stahl's Essential Psychopharmacology, the Mosley Prescribing Guidelines, and the Carlott Medication Fact Book.
All the staples, yeah.
Right. But we're focusing exclusively on targeted symptom treatment for sleep disturbances and nightmares in PTSD.
Which is such a critical area.
It is. And just to be clear, this isn't like a broad overview of trauma theory. This is an advanced, clinically focused exploration of pharmacology for you, the prescriber, on the front lines.
We're getting right into the neurobiology and the prescribing logic.
Exactly. And to keep our pharmacological targets crystal clear today, we're adhering strictly to a rule. We are using both generic and brand names for all the medications we discuss.
Always a good practice for clarity.
Yeah, so you'll hear us say things like prazosin, minipress, trazodone, Decyral, hydroxyzine, Visterol, and clonidine, catapres.
And, framing this strictly around sleep is an intentional clinical calculation on our part.
Why is that?
Well, sleep impairment isn't just like a secondary byproduct of daytime PTSD symptoms. It is the central physiological disruption holding the entire pathology together.
Wow, so it's the core issue.
It really is. I mean, if a patient is trapped in this cycle of fragmented, terror-filled sleep, their prefrontal cortex simply cannot regulate the amygdala during the day.
Because it's just exhausting.
Exactly. Treating the sleep architecture effectively is the prerequisite intervention. It's what makes daytime fear extinction even possible.
Okay, let's unpack this. I want to look directly at that neurocircuitry.
Let's do it.
Because the presentation of PTSD insomnia is fundamentally different from the generalized insomnia we see in, say, a major depressive disorder or a JAD patient.
Oh, completely different.
Right. With standard insomnia, we're usually looking at a failure of the homeostatic sleep drive, like the ventrolateral preoptic nucleus, the VLPO, just failing to switch the sleep circuits on.
Right. The typical I can't fall asleep mechanism.
Yeah. But Stahl's principles suggest PTSD is a completely different beast. The sleep switch isn't necessarily broken, right?
No, not at all. It's actually being actively overridden by the arousal circuit.
That is wild.
Yeah, the brain is locked in a norepinephrine storm. We are looking at a hyperactive locus coeruleus that is just, flooding the central nervous system with adrenergic signaling.
So even when that patient is lying in their own bed,
In a completely safe environment, yeah.
the neurochemical environment is simulating an active, life-threatening crisis.
Exactly. The VLPO is trying to initiate the sleep architecture, but it's just being completely overpowered by the brainstem's survival mechanisms.
Which is why the DSM-5 criterion E6 captures this not just as like a difficulty falling asleep, but as a generalized pervasive state of elevated arousal.
Right. It's an active blockade of sleep, not just a passive inability to sleep.
So it's like trying to turn off a light switch, but the mechanism is physically jammed in the on position by this massive flood of neurochemicals.
That is the perfect analogy, yes. It's jammed on.
But that creates a huge diagnostic friction point
Right.
for the clinician trying to choose an initial agent.
It does.
I mean, if we have a patient sitting in the clinic saying, I can't sleep, how do we distinguish between a patient who just can't fall asleep, your generalized insomnia, and one who is having trauma-driven nightmares?
And you have to make that clinical distinction because it dictates whether your prescription will actually work or just cause side effects.
Right. The biological targets are entirely different.
They really are. So let's dissect the nightmare presentation first. The DSM-5 typically situates nightmares within REM sleep.
Usually in the second half of the night, right?
Exactly. Producing these vivid, complete awakenings with massive autonomic activation. Sometimes these are replicative, like replaying the specific trauma, but often they are just, thematic representations of imminent danger.
But trauma patients don't really follow the textbook REM rules, do they?
No, they don't. And what's fascinating here is how the sleep architecture data shows these autonomic terror responses are frequently initiating during light non-REM sleep.
Wait, like N2 sleep?
Specifically N2 sleep, yes. They are going into a full sympathetic nervous system panic before they even reach deep sleep or enter a dream state.
That is the biological curveball that makes PTSD so difficult to treat with standard hypnotics.
Absolutely. The autonomic nervous system fires so rapidly that the physical panic actually precedes the cognitive narrative.
Wow.
This leads to what the literature terms disturbed awakenings without nightmare recollection.
So the patient wakes up with a heart rate of 130, sweating through the mattress, completely terrified. But if you ask them what they were dreaming about,
They have a totally blank slate.
they just have the physiology of terror without the story.
Exactly. And that ties directly into criterion E4, the exaggerated startle response. These are automatic, involuntary brainstem-mediated reflexes.
So as a prescriber, you have to recognize that you are fighting a hardwired physiological loop.
You are. You cannot expect a patient to use standard sleep hygiene or CBT for insomnia to just breathe their way out of an N2 noradrenergic spike at 3 a.m.
Right, chamomile tea isn't going to fix a brainstem reflex.
It's not. You need a targeted biological agent that crosses the blood-brain barrier and physically blocks that receptor.
Which brings us to the most potent tool in the prescriber's arsenal for this specific mechanism.
Prazosin minipress.
Yes, prazosin minipress. Let's really dive deep into this. We're talking about a central alpha-1 adrenergic blocker.
Right. And Stahl lays this out so clearly. During sleep, the stimulation of central noradrenergic receptors actively pulls traumatic memories to the forefront.
Norepinephrine is basically the chemical trigger for the nightmare.
Precisely. So prazosin minipress acts as a competitive antagonist at that alpha-1 receptor. It effectively prevents the norepinephrine from binding.
It separates the chemical fuel from the engine.
That's exactly what it does.
Yeah.
By blocking those postsynaptic alpha-1 receptors, prazosin minipress blunts the noradrenergic hyperactivation.
But while the mechanism is, super elegant, the clinical execution is where most prescribers seem to stumble.
Oh, completely. The pharmacokinetics demand a very specific titration strategy.
Right, because the Maudsley prescribing guidelines emphasize starting low and going exceptionally slow.
Yes. We typically initiate at 1 milligram at bedtime for 3 days, then 2 milligrams for the next 4 days, and then titrate upward based strictly on symptom response.
And that symptom response creates a massive dosing variance, doesn't it?
Huge variance.
Because I have some case reports where a patient achieves total nightmare suppression on just 2 milligrams a day.
Yeah, that happens.
And then right next to it, data showing combat veterans requiring 30 milligrams or even 45 milligrams a day.
I've seen those exact case reports.
Wait, so if the therapeutic dose doesn't correlate with standard serum blood levels, how does the clinician in a standard 15-minute med check know when to stop increasing the dose?
Well, you're pushing the titration until you hit one of 2 clinical endpoints.
Okay, what are they?
Either complete resolution of the nightmares and disturbed awakenings, or the emergence of intolerable side effects.
Right, because prazosin minipress was originally developed as an antihypertensive medication.
Exactly. So the dose-limiting factor is almost always orthostatic hypotension, or what we call first-dose syncope.
And we should definitely clarify that orthostasis in this context isn't just like a mild head rush when they stand up too fast.
No. The Maudsley guidelines define it strictly. It's a fall in systolic blood pressure of greater than 20 millimeters of mercury, or a diastolic drop of greater than 10 millimeters of mercury within 3 minutes of standing.
For a patient who might be groggy and getting up to use the bathroom in the middle of the night, that's a massive fall risk.
It is a significant risk. It requires meticulous patient counseling. You have to warn them.
Right, because you're prescribing an agent that blunts the baroreceptor reflex, the body's natural mechanism for maintaining blood pressure when you change position.
Yes. Patients must be instructed to sit on the edge of the bed and perform calf flexes before they stand up.
Oh, to pump the blood back up.
Exactly. They have to maintain high fluid intake to ensure adequate blood volume. And some might even need compression stockings. But perhaps the most critical counseling point is about adherence. If they miss more than 48 hours of their medication, they lose that receptor tolerance.
Oh, right. So if they forget their pill bottle over the weekend and try to resume their, say, 10 milligram therapeutic dose on Monday,
they are at a very high risk for severe syncope. They have to retitrate from 1 milligram.
48 hours, start from scratch.
Non-negotiable.
That's a huge clinical pearl right there. But I want to introduce some heavy clinical friction here.
Okay, let's hear it.
Because the evidence base for prazosin mini-press has been highly contested recently, hasn't it?
Yes, it has been confusing for a lot of prescribers.
If we look back at Dr. Murray Raskin's early work, the drug looked like an absolute miracle. Massive effect sizes in combat veterans with the number needed to treat hovering around 2.7.
Incredible numbers.
But then we get to that large, multi-center 2018 VA study, over 300 patients, really rigorous methodology.
I know the one.
And the conclusion was that prazosin, mini-press, showed zero advantage over placebo. So, if the receptor pharmacology is as precise as we just described, how do we explain a massive, well-funded trial showing it basically doesn't work?
Here's where it gets really interesting.
Okay.
That 2018 VA study is the perfect example of why prescribers must analyze the inclusion criteria, not just read the abstract.
What was wrong with the inclusion criteria?
Well, the methodology of that study captured a very specific endophenotype of PTSD that does not reflect the typical acute presentation.
How so?
First, these were chronically stable patients. Second, a significant portion of the cohort was already taking trazodone deserol for sleep initiation, and the study design allowed them to remain on it, and they refused to stop it.
Oh, trazodone deserol already provides sleep onset relief.
Exactly, which heavily confounded the placebo group's response rates.
That makes total sense.
Mhm.
But the most glaring variable was the baseline physiology of the cohort, right?
Yes. The patients in the 2018 study had remarkably low baseline blood pressures before the trial even began.
And that is the crux of the issue.
It is. If a patient has a low baseline blood pressure, their central adrenergic system is likely not in a state of severe chronic hyperactivation.
So prazosin, mini-press, only works if there's an excess of norepinephrine hitting that alpha-1 receptor in the first place.
Precisely. If the synapse isn't flooded with norepinephrine to begin with, throwing an antagonist at the receptor isn't going to change the sleep architecture at all.
It's essentially matching the mechanism of action to the wrong endophenotype.
Right.
It's like giving an antacid to someone with a migraine. It's not that the drug doesn't work, it's just the wrong mechanism for that specific patient's symptoms.
That is a brilliant way to look at it. The 2018 study likely captured patients whose sleep disturbances were driven by completely different neurobiological pathways, not the massive adrenergic storms Raskin was treating in his initial combat veteran cohorts.
Which is why we speculate that higher pretreatment blood pressure is a strong predictor of response.
Yes, a predictor of a specific subtype of PTSD that is highly adrenergically driven.
And this really explains the massive dosing discrepancies we see when comparing civilian populations to combat veterans, doesn't it?
It absolutely does. Treating a veteran with PTSD requires an understanding of chronic conditioning.
Right, because you are dealing with a central nervous system that hasn't just experienced a singular trauma.
No, it has been conditioned by months or even years in prolonged, inescapable threat environments.
Which fundamentally alters the receptor density.
Exactly. We see a profound upregulation of adrenergic receptors in these veteran populations. They present with a much higher hyperarousal baseline.
And severe refractory nightmares.
Yes. The literature consistently demonstrates that male combat veterans often require 10 milligrams, 15 milligrams, or more of prazosin, mini-press, daily to achieve nightmare suppression.
Compared to civilian studies where the mean effective dose, particularly for female patients, frequently hovers around 3 milligrams.
Exactly. And here's where prescriber timidity becomes a huge systemic issue and leads to tolerance and adherence problems.
How does that?
Well, a clinician looks at a veteran presenting with severe replicative nightmares. They start prazosin, mini-press. They titrate up to 4 milligrams, maybe 5 milligrams. The patient reports no reduction in nightmares.
And the prescriber gets worried about the high milligram count.
Right. Even if the patient has perfectly stable blood pressure, the prescriber gets nervous, stops the titration, and marks the trial as a failure in the chart.
It's a systemic underdosing problem.
It is. If the patient's orthostatic vitals are stable and the nightmares persist, the biological target hasn't been saturated yet. You must continue the titration.
So, okay, prazosin, mini-press, is our heavy hitter for the adrenergic nightmares.
Right.
But what if the patient simply cannot initiate sleep in the first place? What if the brain just won't power down?
That's a different problem.
Right, their locus coeruleus is relatively quiet, but their cortical arousal just won't let them drift off. They aren't waking up screaming, they are just staring at the ceiling for 4 hours.
Right, the alpha-1 blockade alone isn't going to initiate the sleep cycle if the serotonin and histamine pathways are driving the insomnia.
Exactly, so that requires shifting our pharmacological target.
Yes, shifting from adrenergic antagonism to serotonin antagonist and reuptake inhibition, the SARI class.
And this is where trazodone Deserol becomes highly effective.
It is, provided you understand its dose-dependent receptor affinities.
Yeah, because trazodone Deserol is fascinating. It basically acts like 3 different drugs, depending on the milligram count.
It really does.
If you push it to high doses, like 150 milligrams up to 600 milligrams, you are saturating the serotonin transporter, the SERT, achieving a robust antidepressant effect.
But clinically, almost no one utilizes it for primary depression anymore.
Why is that?
Because the collateral receptor blockade at those high doses renders the patient functionally comatose during the day. The grogginess is just too severe.
Right. But at low doses, the 25 milligram to 150 milligram range, it doesn't saturate the SERT.
Exactly. It operates like a highly specific, multifunctional neurotransmitter antagonist for insomnia.
Let's break down Stahl's receptor affinities here because it's a perfect trifecta.
Yes. At low doses, trazodone Deserol acts as a potent 5-HT2A antagonist.
And blocking 5-HT2A actively enhances restorative slow-wave sleep.
Right, which is the exact delta wave sleep that is often severely fragmented in PTSD.
Okay, so that's the first action.
Simultaneously, it provides moderate alpha-1 adrenergic blockade and histamine 1 or H1 receptor blockade.
So this triple action turns off the monoamine arousal mechanisms without causing the activating jittery side effects that frequently plague PTSD patients when you initiate a standard SSRI.
Exactly. It's incredibly useful when you have a patient with difficulty falling asleep, especially if they have comorbid depression.
But the pharmacokinetics of trazodone, Deserol, have some serious real-world implications. There's a surprising detail I found in the Carlat Medication Fact Book.
Oh, about the metabolism.
Yeah. Trazodone Deserol is extensively metabolized in the liver by CYP3A4 into an active metabolite called MCPP.
And MCPP is an active serotonin receptor agonist, which is interesting.
But it also carries a very specific, problematic structural similarity. MCPP can occasionally trigger a false positive for MDMA efficacy on standard immunoassay urine drug screens.
Yes, which is a nightmare clinically.
Literally.
Yeah.
I mean, if you have a veteran or a patient in a substance recovery program who takes their prescribed sleep aid and then fails a mandatory drug screen for MDMA, the fallout is massive.
The prescriber has to proactively document this possibility. They have to be prepared to order confirmatory GCMS testing.
That is a critical piece of anticipatory guidance.
Yeah.
Also, another fun fact, food significantly delays the absorption of trazodone Deserol.
Oh, it really delays the Tmax.
Right. If a patient takes their dose immediately after a heavy late-night meal, the absorption is slowed, meaning it might take 2 to 3 hours to reach peak plasma concentration.
Which defeats the whole purpose of a sleep initiator.
Exactly. And it pushes the therapeutic window right into the next morning, leaving them severely groggy and impaired for their morning commute.
It absolutely must be taken on an empty stomach for a rapid hypnotic onset.
And we can't discuss trazodone Deserol without addressing the rare but strictly emergent side effect for male patients.
Priapism, yes.
It's rare, right?
Very rare, but serious. It's driven by the drug's alpha-adrenergic blockade affecting the vascular outflow of the corpus cavernosum.
And if a prolonged, painful erection occurs, it requires immediate emergency department intervention.
It is not something that can wait for a morning clinic call. It can result in permanent ischemic tissue damage.
Okay, so we have the alpha-1 antagonist, prazosin minipress, for nightmares, and the SARI trazodone Deserol for sleep initiation.
Right.
But what tools are left in the toolbox when trazodone Deserol or prazosin minipress aren't appropriate? Or if the prescriber needs an acute short-term bridge.
Like an acute anxiety spike.
Exactly. A patient comes in, maybe it's the anniversary of their trauma, they're in a state of severe transient hyperarousal, and you don't have the luxury of a 3-week titration schedule. You need a PRN option tonight.
In a strictly acute window like that, we frequently utilize hydroxyzine as sterile.
Which is an antihistamine, right?
Correct. It is a highly lipophilic antihistamine that easily crosses the blood-brain barrier to selectively block central H1 receptors.
So it promotes sleep and manages acute anxiety.
It does. It provides rapid sedation.
But the clinical utility of hydroxyzine Visterol in a chronic condition like PTSD hits a massive physiological wall pretty quickly, doesn't it?
It does, and that wall is the rapid downregulation of H1 receptors. The central nervous system adapts to H1 blockade exceptionally fast. If a patient uses hydroxyzine Visterol every single night, they will develop profound tolerance to the sedative effects.
Like within weeks.
Often within a matter of a few weeks, yes. It basically ceases to be a sleep aid and just becomes an inert pill.
So it's completely impractical for the chronic long-term management required in PTSD.
Exactly. It is exclusively a short-term PRN tool, a band-aid for an acute crisis, not a foundational treatment.
Which forces us to look for alternative sympathetic modulators. Like if a patient cannot tolerate prazosin minipress, perhaps the orthostatic hypotension is unmanageable regardless of hydration, we often turn to clonidine, cataprase.
Clonidine cataprase is a very interesting alternative.
It is, but it represents a completely different approach to the adrenergic system, right? Because while prazosin minipress blocks the postsynaptic receptor, clonidine cataprase is a central alpha-2 receptor agonist.
And using an agonist to reduce hyperarousal is a concept that often trips up practitioners.
It sounds counterintuitive.
It does, until you look at the presynaptic anatomy. The alpha-2 receptors function as presynaptic autoreceptors.
Like a negative feedback loop.
Exactly, like a thermostat. When the locus coeruleus releases norepinephrine into the synapse, a portion of that norepinephrine binds back onto these presynaptic alpha-2 receptors.
And that binding sends a signal to the neuron to halt further release.
Precisely. So clonidine cataprase is essentially chemically tricking the brain.
Wow.
By agonizing that alpha-2 autoreceptor, it convinces the locus coeruleus that the synapse is already flooded with norepinephrine.
So it causes the brain to aggressively shut down its own sympathetic outflow.
It forces the system to stand down. It acts as a global sympathetic dampener.
That's incredibly useful.
It is, especially in pediatric PTSD populations or in adults where the localized alpha-1 blockade of prazosin minipress isn't tolerated.
But because it reduces systemic sympathetic outflow globally, rather than just locally at the alpha-1 site like prazosin minipress, the side effect profile requires intense monitoring.
Oh, very intense. You are inducing an overarching dampening of the autonomic nervous system.
Which means profound risks of bradycardia and systemic orthostasis.
Yes. And the pharmacokinetics make this tricky for isolated sleep treatment.
Why?
Clonidine, cataprase, has a half-life of roughly 11 to 12 hours.
Oh, wow.
So if you dose a patient at 10:00 p.m., that sympathetic blockade is still heavily active at 10 a.m. the next day.
You risk creating a patient who is severely fatigued, dizzy, and hypotensive during their active waking hours.
Exactly, which is why symptom-driven prescribing logic is the only way to navigate these waters safely.
You have to match the pharmacokinetic profile and the receptor affinity to the specific clinical presentation.
Yes.
With the major players on the board, let's map that symptom logic out explicitly for the listener.
Okay, let's break it down. If the primary clinical barrier is replicative trauma themes, intense autonomic terror during sleep, and disturbed awakenings.
Your primary target is the alpha-1 receptor.
Exactly. And the drug of choice is prazosin minipress.
Okay.
But if the barrier is high cortical arousal preventing sleep initiation, tossing and turning with comorbid depressive symptoms?
You target serotonin and histamine modulation.
Right. The drug of choice is low-dose trazodone and deserol.
And if the patient presents with severe generalized hyperarousal that pervades both day and night, and they have failed localized alpha-1 blockade,
you utilize the alpha-2 autoreceptor to force a systemic sympathetic step-down. The drug is clonidine.
cataprase.
And for strictly acute transient spikes in anxiety where you need a short-term, rapid-acting bridge without building long-term architecture, you utilize the H1 blockade of hydroxyzine, Vistrol.
That is a brilliant breakdown. But, clinical reality is rarely that cleanly compartmentalized.
Never.
Patients don't present with single symptoms. Let's say I have a patient who has horrific adrenergic nightmares, and they lie awake for 3 hours before they even fall asleep to have the nightmare.
A very common presentation.
Right. So can a prescriber combine these agents? Like, can you safely co-administer prazosin minipress and trazodone deserol?
You can, but it requires extreme caution and an advanced understanding of synergistic pharmacodynamics.
Because of the overlapping receptor profile.
Exactly. Look back at Stahl's profiles. Prazosin minipress is a dedicated, potent alpha-1 antagonist, but low-dose trazodone deserol, alongside its 5-HT2A and H1 effects, is also an alpha-1 antagonist.
You're literally doubling the alpha-1 blockade.
You are. You're creating a compounded additive hypotensive effect.
So the risk of severe orthostasis and syncope just multiplies.
Exponentially. If the clinical severity necessitates polypharmacy to achieve both sleep onset and nightmare suppression, the titration schedule must be extended significantly.
And orthostatic vitals have to be tracked meticulously.
Yes, measuring blood pressure while lying flat and then again after standing for 3 minutes at every single dose adjustment.
If we connect this to the bigger picture, treating PTSD isn't about throwing sedatives at the wall.
No, it's about matching the exact receptor profile to the exact neurobiological symptom.
Which brings us to a really important point. Knowing what to prescribe is only half the battle. Knowing what not to do is just as crucial.
Oh, absolutely. The clinical mistakes can be devastating.
Let's dig into those common clinical mistakes. We've established that mistake number 1 is prescriber timidity, failing to titrate prazosin, mini-press, high enough due to fear of the milligram count.
Yes, undertreating the adrenergic storm.
What's mistake number 2?
Utilizing an agent like trazodone, Desirel, as the sole treatment plan for a PTSD diagnosis.
Oh, ignoring the daytime symptoms?
Exactly. Trazodone Desirel will initiate sleep, but PTSD is a 24-hour neurobiological disorder. If you only provide nocturnal sedation, you are completely ignoring the daytime pathology.
The hypervigilance, the avoidance behaviors, the intrusive flashbacks.
Right. It is an inherently incomplete intervention. And that leads into mistake number 3, which is relying entirely on generalized sedatives.
Which brings us to the major avoidance, the elephant in the room. I know what the clinician listening to this is thinking right now.
I think you too.
You are staring down a 15-minute med check. You have a severely distressed, exhausted, crying patient sitting across from you. They are begging for a quick fix, a way to just turn their brain off tonight.
And the easiest, fastest way to get them out the door feeling relieved is to write a script for benzodiazepines.
Exactly. Alprazolam, clonazepam, lorazepam, they work instantly. So why are benzodiazepines considered the ultimate red flag, the absolute major avoidance in PTSD pharmacology?
I will give a firm clinical warning here. Prescribing a benzodiazepine in PTSD is the pharmacological equivalent of prioritizing an immediate illusion of calm while actively sabotaging the brain's long-term ability to heal.
That is a strong statement. Break that down for us.
Let's examine the neurobiology of fear extinction.
Fear extinction, which is the ultimate goal of any trauma therapy, right? Whether it's EMDR, prolonged exposure, or cognitive processing therapy.
Yes. The brain has to learn that the traumatic memory is historical, not a current active threat.
Okay, so how do benzos interfere with that?
To achieve fear extinction, the brain relies on neuroplasticity, specifically long-term potentiation in the amygdala and the hippocampus. The neural pathways must form new, safe associations.
Right.
Benzodiazepines operate via positive allosteric modulation of the GABA-A receptor. They flood the system with inhibitory signaling.
Which feels good in the moment.
It instantly blunts the subjective feeling of panic, yes, but that massive GABAergic suppression actively inhibits the exact neuroplastic processes required for fear extinction learning.
Oh, wow. You are chemically paralyzing the brain's ability to process the trauma.
Exactly. A patient can take clonazepam daily, sit in EMDR therapy for 5 years, do all the hard psychological work, and the brain will never actually reconsolidate the memory.
Because the medication is blocking the physical neural pathways required to learn safety.
It is definitively worsening PTSD outcomes long term. Furthermore, benzodiazepines severely disrupt healthy sleep architecture.
They suppress deep, restorative, slow-wave sleep, don't they?
They do, and they fragment the overall sleep cycle. When you combine the suppression of slow-wave sleep with the active inhibition of fear extinction, the clinical data is definitive.
It carries a high risk of dependence too, right?
A severe risk of physiological dependence in a patient population that is already highly vulnerable to substance use disorders as a coping mechanism.
So what does this all mean for the clinician staring at a desperate patient asking for a quick fix? It is a profound ethical challenge.
It really is. Clinician education and patient expectation management are critical here.
It requires looking the patient in the eye and saying, I know this pill would make you feel better tonight, but I will not prescribe it because it will cement this trauma into your neurobiology for the rest of your life.
Managing that expectation, validating their distress while holding the line on evidence-based pharmacology is incredibly difficult. But it is the absolute standard of care.
We must treat the underlying neurobiological architecture, not simply anesthetize the distress.
Exactly.
Well, we have covered an immense amount of clinical ground today. To briefly recap and synthesize the core logic for you, the prescriber, PTSD sleep disturbances are distinct neurobiological events requiring targeted pharmacological interventions.
Specifically manipulating adrenergic and serotonergic pathways.
Right. We utilize adrenergic agents like prazosin, minipress, and clonidine, catapras, to dismantle the brainstem's nightmare engine.
And we leverage serotonergic and histaminergic modulators like trazodone, deserol, and hydroxyzine, vistarol, to overcome cortical arousal and initiate sleep.
If there is one overarching concept to retain from this deep dive, what would you say it is?
I'll leave you with this final thought to mull over. Sleep treatment is absolutely essential in PTSD, but it is never sufficient alone. If a patient is not sleeping, they cannot engage in the daytime fear extinction and memory reconsolidation required in trauma-focused therapy. You are repairing a sleep architecture so the mind can finally do the work of healing.
You are fixing the X-ray machine so the patient can finally see the break and the real work of setting the bone can begin.
Exactly.
Next time, we are moving beyond the nocturnal neurobiology. We will be exploring augmentation strategies in PTSD pharmacology to directly tackle the stubborn daytime symptoms of severe avoidance and hypervigilance. Thank you for joining us on this deep dive into the source material. We will see you next time.